I'm about to hit broadcast and we'll give it about 5 seconds and then we'll go, okay?
Yep.
Okay.
Here we go. Hello everyone, and thank you for joining us. You are participating in the third webinar in our 4-part series, Responding to Domestic Violence and Situational Grief, a primer for mental health and spiritual care professionals. Today's topic is an overview of situational grief and strategies for responding. Our speakers today are Dr. Claire Bamberg in Vermont, who will be taking the lead for this particular webinar, and Ms. Dawn Starry in California.
Thank you, Janelle. Before Claire starts, I just want to again introduce myself. My name is Dawn Starry. I'm a pastoral counselor working in San Diego. My experience has been primarily with refugees and asylum seekers who are primary and secondary trauma survivors. And in that work, I've come across issues of intimate partner violence and domestic violence. And then next week, Claire and I will be wrapping up together talking about what the commonalities and differences we see in both of the topics that we presented. So now I will yield to you, Claire, and have you take it over from there.
Thank you. Hi, I'm Claire Bamberg. I started into my professional life through training with hospice and was, for what I hope is a very brief period of time, the youngest trained pastoral caregiver, so they said. And then I moved on to the Brigham and Women's Hospital, where I did 4.5 units of CPE. I was also on call with Children's Hospital in Boston. They didn't have any chaplaincy services at that time. And I've gone into parish ministry and done a lot of things since. One of the things that I've come across, and one of the things that I've begun to speak about nationally, is managing grief. Like, what is it? How do we deal with it? And today what I'm going to try to do is to cover that topic from a number of different points of view. So one is from your position, those of you who are educators. How do you work with the chaplains? How do you assess? How do you address when they're triggered? How do you help them be attentive to their patients? What kind of training modules do you need to provide for them? How do you build that into the program? And then also a little bit about what you actually can see and what's going on in those first moments where somebody is dealing with either the news of a loss or the loss themselves, or they're triggered, all those things. I'm going to ask that you feel free to submit questions through the Q&A tab on your screen. And Dawn and Janelle will curate and ask those questions for you. And I'm going to, just so you can see them coming, I'm going to pause at the end of each slide and see if there are any questions. I'm a very didactic presenter. It actually gives me something to work with if you go ahead and submit those questions, again, through the Q&A, or if you think about them afterwards, if you're one of those people who processes and kind of works things through afterwards, you can write directly to Janelle, and she will get those questions to us. So I'm going to screen share, and I think I'm going to screen share. I'm not sure what's happening right now. There. And begin to work through. So again, questions, comments, concerns, please address them through the Q&A or to Janelle directly through email. So these are some of the things that I hope to accomplish today in depth. Some of these we went through very briefly in the first week that we were together, and I hope to expand upon those with you today. To understand the circumstances under which grief occurs, briefly, and so you can be listening with this in mind, grief is a component of any change that people go through. So grief comes with a job change. Grief comes with relocating. Grief can come with the loss of a limb, the loss of a pet, in addition to the traditional ways that we think about it, the loss of an individual with whom we have a primary or close relationship. So the first thing that I want to help you do is lessen your anxiety. In part, that I hope will be accomplished through this webinar and ongoing conversations that we may have. I should say that I am willing and available to also work with people and address questions that are kind of more like case presentations. If we don't have time today, Janelle will know how to reach me with any questions that you have. One of the things you can also do, and I'll go through this some more, is to identify what your resources are. You cannot, in circumstances where somebody's been triggered or they're dealing with traumatic grief, you cannot be the only resource. And it's important for your sake that you not put yourself under that kind of pressure. So I'll list some resources for you today. I'll tell you where to find others. As educators, this is a phenomenal resource for you to have available for your chaplains in a place that's been identified, like a lending library, if you will, where they can go and look these things up. And for your chaplains to have an additional and sometimes very different set of resources for their clients or patients. It's going to be important to identify the different ways in which grief manifests itself. I'll go through that a little bit at the very end in terms of the chart that I prepared for you. There is, it's important to understand that there is a difference in the way different age groups manage grief and loss and trauma, different developmental stages, which is not always attached to age, but can be. Depending on the amount of resources that somebody has, if they are firmly resourced in a strong supportive family, they're going to respond very differently than somebody who is marginalized. And then their position in the family and circumstances. There are people who are cast in a role of being the one who, manages these things perfectly. And there are other people who have permission to come completely unglued. And they may be in the same family, assigned different roles, and this will play out as they address grief. This, again, is important for you educators to understand when you're looking at people in your programs. And then what I'd like to we're going to be able to do today is to equip the clinicians, you and the chaplains, with tools to manage the most unexpected of grief presentations. So I'm going to pause. I'm going to see if there are any questions that have come in so far.
Okay. Claire, there haven't been any questions that have come in so
Thanks,
far.
Dawn. Okay. So, promised resources. Your local hospice, some of you may have palliative care departments in your facilities. You may also have hospice in location. There are different models of hospice, so you may need to look outside of your facility. And if you don't already know, it's going to be important for you to know the difference between palliative care and hospice. There are a couple of books, in addition to being a well-known expert, quote unquote, on death and dying, Elizabeth Kubler-Ross has written. I particularly appreciated her book, which is not listed here. It's called Death, the Final Stage of Growth. The ones that are more specifically geared to our purposes on death and dying, what the dying have to teach doctors, nurses, clergy, and their own families. Very important resource for you to have in a library. And the other one called Life Lessons. Please have on hand not only water bugs and dragonflies, but if you're not already familiar with it, a booklet called Gone From My Sight, which helps people identify the stages of death that start from 3 months out to 3 seconds out. Dawn mentioned this one. I also find it very helpful for people. It's called Trauma and Recovery. It's by a woman by the name of Judith Herman. And then Sherwin Newland, and many of you being located in hospitals may have already been acquainted with this one. Sherwin is an MD and began to do some studies from within chaplaincy services, from within his own life. And he's written a book called How We Die, Reflections on Life's Final Chapter. The other resources to assess when you're dealing with people who are in traumatic grief, first responders, etc., have to do with the resources around them. These are resources that are external to them. They're research that you can do, support groups that you can put people in touch with. Okay, for the educators. So both in my presentation in Scottsdale and 2 weeks ago, somebody asked about assessment tools. I spent about an hour on the phone this morning with Melissa Walker-Luckett, who is your incoming president. She and I have known each other for about a year, and we have agreed to work together to develop an assessment tool for all the educators to use during the interview for people to enter your programs. So I just want to let you know that. We'll cover not only grief triggers and trauma triggers, but also the kinds of triggers that Dawn's been talking about and others. If there's something that you specifically want to see added to that assessment tool or considered in it, please write to Janelle and she will get that to us. We're also going to collaborate together to provide you all a list of the referral resources that are available in your area. We knew going into this that in addition to being support clinically for our ACP brothers and sisters in clinical settings, we would also be a resource for discharge planning. So when you're dealing with your patients, if one of your chaplains comes across somebody who they really believe needs additional help, you will have available for them the former pastoral counselors, the ACPE psychotherapists in your regions, and what their specialties are. In addition, you educators will have an opportunity to have a list of those similar resources highlighted for referrals if you have a clinician who, one of the presentation case studies was a gentleman chaplain who went in to be with a family who had sustained a fetal demise, and he came completely unglued in that circumstance such that the family ended up having to take care of him. That's just one case study. Should that happen, you will now have a resource to which you can refer him, in addition to the fact that with the assessment tools, hopefully we'll have questions developed so you can see that coming. And you can use it in advance as a condition of acceptance. So, okay, you've got this background, you've dealt with this in a certain way. Maybe it's domestic violence or intimate partner violence. Maybe it's traumatic loss. Maybe it's unresolved grief. Maybe it's any one of the number of other things that we'll address in the assessment tool. Who's helping you? Where would you go if you were triggered? And we would like you to have ongoing support while you're in this program. Here are some names. It's going to be another thing that we're going to take a look at is figuring out how can we provide you a module that you can include in your training that will cover some of these things in such a way that you are equipping people before they get in the room, before they're triggered, so that you and they can see it coming and it can be a part of their training. This is an important consideration, we believe, not only for you as the educators, so that you can have some confidence going into this, that you've got people who are resourced beyond you, but also for the other students in the program, and most especially for the patients that they'll be working with. Included in the training module will be a segment on how and when to make referrals. Where do you know that you're in over your head? What do you do to manage that? And then what I'd like to also make available to you and talk about for just a minute is, what do you do when your student is triggered? So I'll do a lot of quoting this one particular part of something that Dawn said last week. And the first thing to do is to remember to breathe. If your student is triggered, to be able to sit and listen, to act a little bit like a combination of sounding board and debriefer. And then to begin to ask questions about, is this the first time this has come up for you? Do you have any kind of awareness of what triggered this? Is there someone you can call? Are you okay to stay here today? In many instances, whether they say it or not, their answer should be no. And if you can see that they're that triggered, you ask them to call someone and be sure that they won't go home alone, or that they have a place to go where they can begin to work that out. And then to remember that you yourselves will need to do some self-care. So whether you're a chaplain who's dealing with somebody who's having a traumatic triggered response, PTSD or dissociative, that can happen. To remember that you also are being secondarily traumatized in those moments, and you taking care of yourself is going to be huge. One of the statistics that's come out as we've been doing the work with ACPE and our strategic partners is the realization through a study in the Mayo Clinic that last year, in excess of 400 physicians died by suicide. That's the equivalent of a small medical school. You deal with clinical trauma every day, and the necessity of taking care of yourself is something that we don't continue to educate around once people attain a certain professional status. And it is most emphatically then that ongoing care, self-care, needs to be an important part of our everyday. Okay, I'm going to stop before I go on and see if there are any questions.
There aren't any at this time.
Okay, great. So for chaplains yourselves, to take a module on grief and the grief cycle, based on the response, I'm anticipating that we'll probably be putting together another workshop or a webinar series that people can take, maybe a one-time or two, around the grief cycle, so people understand what is normal and when to refer. I'll be talking about that a little bit before we get off today. And then to figure out what can be done in that moment. So let's talk about that for a moment as a chaplain. You walk into a room, you sit down with someone, and as you sit with them, you begin to realize that they've sustained a traumatic loss. Now, again, please remember, this can have anything to do with relocation, job loss, limb loss, relational loss, or in some of the instances that Dawn talked about last week, a loss of a sense of safety or personal agency. One of the first things you want to do is to help people understand that most often the feelings that they're having, the physical reactions they may be having are normal. And then to begin to talk about resources. I remember when I was at the Brigham at one point, we talked about how people evidenced what they were feeling in somatic responses, such that there was one woman, again, case study, who was given a diagnostic category. She found, again, the analogy, the metaphor, difficult to swallow, because she began projectile vomiting as soon as the physician left the room. It's helping people to understand and make sense out of whatever physical responses or emotional responses they may be having. And then through understanding where they are developmentally, to be able to equip them with resources. And then to do a brief assessment for resources. So what are their familial attachments? How strong is their family? Are they enmeshed? Are they disengaged? Do they have a faith tradition that provides them some support? Are they connected to a faith community? Are there community resources? Is there a local hospice? Is there a local area agency on aging? Is there someone who can move in and do an assessment? And again, remember, you'll have some resources in terms of community, referring them to ongoing pastoral care or mental health resources. What are their personal resources? What do they know about themselves? When have they been through this before? What helped them then? And then theoretical resources, some of the written materials. I'm going to pause. I think a question has come in.
Yes. So the question is, what qualifies a loss as a traumatic loss?
Ah, good. So thank you for that. So on the spectrum of losses, there are losses that we can see coming. I'll get into this a bit when we get into the chart. And those losses give us an opportunity to psychologically, emotionally, and in some cases, prepare resources to brace ourselves, cushion ourselves, insulate ourselves, provide denial, whatever we're going to do as human beings to mediate that. A traumatic loss has to do with a suddenness, the unexpected nature of the loss. It can also have to do with a degree of violence. So the trauma can be visited upon us in a number of ways. Usually it's the suddenness, the degree of violence, and the lack of resources that make it more or less traumatic for individuals. If there's a follow-up question, please go ahead. So this is part of what makes it traumatic, is that you don't see it coming. And so both in addition to the traumatic loss, the trauma that we sustain as helping professionals is when it comes out of the blue. It's one thing when you know you're visiting somebody who's dealing with that, or they have that diagnostic category. It's another to walk in a room or to be walking down the street, as Dawn talked about last week, and all of a sudden realize you're dealing with somebody who's a survivor. In the grief world, it's you're dealing with somebody who, if you're an educator, hasn't dealt with their own grief and has now been triggered. Or if you're a chaplain in a room with someone that you didn't realize that they had sustained a deep or significant grief. Or you're actually in the room with a family when there is a demise and they didn't see it coming. Then what do you do? So to quote Dawn, it's very, 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 very important to breathe. And I'm not just saying that euphemistically, to give yourself permission, psychological cushion, to stop and take a breath. Your non-anxious presence, you who are sitting in the room with that person, is going to be the most important resource you and they have. We all know the effects of cortisol and adrenaline. They go right to the frontal lobe. They compromise our ability to think. So doing what you know you need to do to maintain executive function is going to be the most important thing you can do in those moments. Do not reach out and try to touch the other individual, even if it means you mean to be reassuring without asking permission. Even something as particular as, would it be all right with you? Would it be helpful for you? May I offer you? And do not, if please, take it as a personal offense if the other declines, and do not go ahead and touch if they don't say anything. Take that as a no in that moment. Assess, assess, assess. Have you had anything like this happen before? What are your resources? What do you know about yourself? How might I be of help right now? Is there anything that you can identify that I might be able to say or do that would be helpful to you? Would you like to pause for a moment in prayer? Assess where the individual is and what they may be needing in that moment. Again, what's really helpful, and you all know this as educators and chaplains, The more we know about ourselves, the more we can actually get out of the way and be present to what the other individual may need that's different than what we would want. And then resource, and in some instances, refer. I'm going to pause. I think there's another question that's come in.
So this is a follow-up from the earlier question about traumatic loss.
Mm-hmm.
It's a comment saying, so very significant losses are not always traumatic.
That's correct. That doesn't mean they're not impactful. There are instances where you've got a very significant, a primary loss, but you've got the grace of months, or in some instances years, to be able to do the pre-grieving, the pre-planning, the assessing for resources, the conversations that are necessary to feel like you've got closure. So though it's an impactful loss, it's not a traumatic loss. Traumatic losses are when people have not had the closing conversations, they have not had a chance to see it coming, they have not had a chance to prepare the resources, and they have not had the luxury, and that's in quotes, of dealing with some of their own emotional needs pre-grieving. I hope that's helpful. So this is, oh, we got another question. I'll wait.
It's actually just gratitude, saying thankful, or saying thank you, very helpful.
Good, good. So this is a copyrighted piece that I have that I've actually built upon by a gentleman who has since died. His name is Bill Lemiers, and he operated out of the Marin County Hospice in California. I'm about to make more changes on this, so I'm offering it to you. There will also be some revised opportunities to take a look at this in a subsequent series. At the moment of law, so when you look at this, and I think you can see my cursor on the screen, that what's inside this circle here are what people feel. What's outside the circle here are what we see them going through. These are names of the various developmental stages of grief. And it's very, very important. I can't say this enough. I probably won't be able to say this enough in the time that we have, to understand that people do not move through this in a very neat fashion. What I say is, if you take this inner circle, the designated circle, and you treat this like this is a wall, 3D, so the wall comes up, and you set a gyroscope loose somewhere in this area, the way the gyroscope would go is pretty much the way people move through this. However, that said, people generally start at protest and end moving from detachment into what is now going to be called re-entry. I'm going to stop and see if there are any questions at this point.
So the question is, what exactly is pre-grieving, especially if it is an unexpected loss?
So those are two separate things. Pre-grieving has to do with when you can see it coming. So when my brother-in-law was diagnosed with metastatic prostate cancer, they were given 6 months to 6 years for him. So what that allowed them to do was to have significant conversations with family and friends, to pre-grieve, to cry together, to plan the way the funeral service would look. One family I worked with, we actually had a funeral service including the about to be deceased. So people could, in the context of worship and celebration, say what they needed to say to the one who was dying. So pre-grieving is you go through these elements of grief, but you do it before the loss actually happens. In traumatic loss, you don't have an opportunity to do any of that. That loss triggers this, and in a very shocking and difficult way, such that some people have difficulty even getting past the denial. For instance, when the school called my cousin to say that her mother at 54 years of age had died standing in line to get tickets for a performance that night, my cousin's response was to say, "That's not possible. You must be talking about my grandmother." So there, in a traumatic loss, a sudden loss, there's an increased likelihood of denial as a first response. In all losses, these first three emotions are what happens at the moment of notification of the loss: the shock, the confusion, and the denial. As a hospital chaplain, there were times where I sat in a room with somebody where I knew that last breath was coming, which, by the way, is what is very helpful about the resource gone from my site. And even at that last breath, at that last moment, sitting there, knowing it was coming, I was like, wait, what? So the shock, the confusion, the denial of what's actually taken place has degrees to which it's functional in those first moments. Another thing that comes along is anger. That can be anger at the institution. All of us have dealt with that, where a family that's lost, had a traumatic loss or a sudden loss, or even an iatrogenic loss, has anger at the institution, the doctors, the lack of whatever happens in those first moments, and then anger itself. And the anger itself can be something as simple as, if only I had done this and such, or why didn't I take more advantage? And it can go all the way to this spectrum where I've seen people start hitting themselves, or, you know, other ways of holding themselves accountable in anger for something over which they had no control. And the final first things that people feel, and this is cultural, and it remains ongoing as people move through this and through their lives, is a sense of what Bill called lowered self-esteem. Really what it is a kind of a sense of disorientation. We are relational people. We know ourselves in terms of the relationships that we have. I'm my parents' daughter, I'm my brother's sister, I'm my children's mother. And when one of those significant relationships is lost, so have we lost a way of knowing ourselves in the world. If you can imagine a ship moored, it's as if somebody cut one line. So there are still other ways of knowing myself, but that line has been cut, and I'm a bit adrift. I'm going to stop and see if there are any questions at this point before we move into the other half of the circle.
Yes, so there was a question asking if there is a connection between your diagram and Alan Wolflet's theory of needs during the grieving process. That's one of the first questions.
Mm-hmm. And I would need to go and I don't want to answer that just off the cuff. I'm not familiar with Alan's work. I'd want to go research it and make an informed response to that question.
Okay. Somebody's asking if they can have a copy of the diagram.
I would, so the short answer to that is not right now. Yes, eventually that'll be available through ACPE. Right now, what I want to do is give you a more accurate one. I'll talk you through those things that are being changed, as I just did, where recovery is going to become reentry, and I'll explain why in a moment. And then I'd like, yes, definitely to make the diagram available in an updated form. The other thing to say about that is this is for you. This is not something, unless you've had training in this, that I would encourage you to speak with certainly patients about with authority. This is a resource for us. So okay to go on? There aren't any others?
And this is one I can answer. The question was, can people get a copy of the slides from today's class and the previous ones?
Yes.
They can, yes. And then just a reminder, and we'll remind you again at the end, that this is being recorded and is on the ACPE's YouTube channel that you can access from their website.
Yeah. And if you want a when the diagram is updated, if you want an actual copy of that, please let Janelle know, and I will send you one that you can print and have for yourselves. Good to go?
Yes.
Okay. So as I mentioned earlier, what's inside the circle is what people experience inside. Those are the emotional responses. What's outside the circle is what we see and experience of the individual who's experiencing the primary state of grief. I want to say, remember that even within the same family system, even within intimate relationships, people manifest grief in as unique a way as we are from one another. So there's no template and there's no checklist. There's an ability to see this coming and figure out how to manage this, and that it's all quote unquote normal, depending on the person who's experiencing it. So some people in that moment experience sometimes a florid emotional response, crying, physical pain. Some people will grab, their heart or their stomach. They have some physical pain. Some people experience weakness. Thank God I was standing behind someone who, at the point that their intimate loved one died, lost strength in their legs, and I was able to catch them before they hit the hospital floor. Sometimes nausea, literal nausea, like a physical need to leave the room. Some people experience a loss of appetite. I'll do the opposite in a moment. So this is something to be careful about. If people go too long without this, obviously there are going to be other things that come along as a byproduct. Sleep disturbances. So some people, I'm going to do both sides of this one. Some people can't get out of bed, and some people become so anxious they can't get in bed. Now this is one that's particularly important to pay attention to when you're dealing with children. Do not tell a child that so-and-so went to sleep. If you do, you deserve to be up for 3 weeks. So to be able to be honest with a child about something that's taken place, kids do something called bubble up. I call bubble up. I don't know what other people call it. Where they ask unique questions in the moment. And depending on their age, so kids develop an ability to abstract think in about the end of 4th grade, so around the age of 10. Until then, their questions are quite literal, and they're only asked in that moment. So if you're preoccupied or busy or move on, and this is important if you're in the room with an extended family, or you're in the room with your own family and you're going through this, a child will ask a question. The most important thing you can do is stop in that moment and answer their question, and answer the question they're actually asking. Kids ask interesting questions. 3-year-old son of a friend of mine, when they were doing the interment service, asked if Grandma's special flowers were going to grow up where she was planted in the spring. So his mom made sure to go out and get tulips and plant them at the gravesite. So the next spring when they went there, he could see that Grandma was happy. So those things. The other thing to be very careful about is not to say to a child, so-and-so has gone to be with God, and then all they can see is somebody crying all around them. What I've learned to say to children is that, part of their body, an important part of their body, stopped working. And they died. And this makes hospitals a lot less frightening to children if they understand that people can both get well and not get well there. So it's not about the hospital did something, but a part of their body stopped working. Okay, that's a tangent. I can come back to more questions about kids if you want to. So what happens in these first moments is spectrums happen, polar ends of spectrums. So people are either crying or they can get very stoic, a completely flat affect. This is different than depression. It's a kind of a frozen thing. It's not going to last as long as a clinical depression, although it may look similar. In addition to the weakness, there are some people who get tough, and you can see an unnatural rigidity to them in that moment. These are usually the people who are going to be expected to carry the rest of the family through whatever the aftermath of the loss is. In addition to people who sometimes lose appetite, there are people who overeat. One of the stories I told after at the workshop in Scottsdale is that after my daughter died, and she died at 17 weeks, I couldn't stop eating. I didn't want to not be pregnant. And my dealing with her, losing her took on a very physical response to that loss. People who can't get out of bed, this may be of more concern to family members. You may get phone calls about this. You may have your own concerns about that. This would be something where you may need to make a referral to a professional. As a pastoral counselor, I work with people who need to be on antidepressants for like the first 2 weeks of the loss, just to keep their neurotransmitters in balance, and then they're fine to go ahead. So these are just resources and things for you to keep in mind. And then there are other physical changes, as unique as we are individuals. This, again, I just want to reiterate, you don't go through these necessarily in order. I'm moving through them, quote unquote, in order, so that you have the information. I do want to pause, though, before I go on to the next segment, and to see if there are any questions.
There hasn't been any that are written in, but I have a question for you, Claire.
Great. Okay.
I'm thinking about a client I have who had been depressed, clinically depressed for quite a long time, and then was recently becoming more stable.
Mm-hmm.
And then she had a significant loss of a loved one in her family, someone she was very, very close with. And so both myself and the psychiatrist are keeping an eye on that. But if you could talk a little bit about the sense of somebody who has, who maybe has depression, or if there's another issue going on, and then they meet with a loss like that.
So somebody who has any kind of depressive tendencies, so whether you've got somebody who's cyclothymic, bipolar, major depressive episode, dysthymic, this kind of thing, particularly around sleep. So neurotransmitters are manufactured, among other ways, in the sleep trough. So the minute you begin to have sleep disturbances or disturbance in the quality of sleep, you're going to, particularly with those people, be on red alert around the possibility of a clinical depression or a bipolar break. And so this is one of those times where you would not be looking to remove a resource, particularly a psychotropic resource. That this would delay that, not necessarily for the year to year and a half that it takes to move through that, but certainly until you and they could agree that they were kind of out of the woods, well into this and managing it, quote unquote, well. The other thing to keep in mind for everyone who's listening is seasonal affective disorder. So if I'm working with somebody who, and it's October in the Midwest, certain portions of the Midwest or New England or the Pacific Northwest, and they have a significant loss, that's going to affect them differently than if it were March or April, because of the vitamin D that the sunlight gives us that metabolizes those neurotransmitters. So these are all things to keep in mind. When Melissa and I were talking this morning, this would be one of those places where you as a chaplain or an educator, if you're needing to make a referral, this would be the time for you to engage the resources, either supportive resources, call someone like us, or make a referral to someone like us, so you can know what you're looking at and how best to manage that for your student or your patient. Is that helpful, Dawn?
Yes, that is. Thank you.
What you're looking for. Okay. So as you move into this next phase of grief and loss, the physical changes continue. And again, those are as unique as we are individuals. what happens, this is the point in the grief cycle where I get calls from the individuals themselves, because these next two things that we see on the outside, as they feel them, freak them out. They're very disturbing. So I think most people on the line today will have at some point in time in their lives pulled an all-nighter. And if you're self-aware at all during the day after you've pulled an all-nighter, you're aware that you're actually, my mother calls this, you look like you're moving through molasses in January. So you're slowed down, your physical responses are slowed down, somatic, you look a little leaden. This also happens with thinking. So it's like somebody has taken a video of you, both in your thinking and in your movement, and played it back at 1/2 to 3/4. And this is very disturbing for people. I'll get calls, I'm going crazy, I'm not thinking right, I can't think anymore, I'm frightened. This is, although unpleasant, a normal phase in the grief cycle. And it has to do with this whole deepening of the emotional impact of the loss. So at this point, we move into grief. If this is the somatic response, the anger, all the confusing emotions that come at those first moments of loss, this takes us deeper in. I want to say a word about this. This is also going to be rewritten. This is not clinical depression. This is the cultural definition of depression, which is better recognized as deep sadness or grief. So this is where the anguish, the agony of the loss become a daily thing. Sometimes people report, I'm going along and all of a sudden, some clients call it whoosh. Some people feel like it's like an undertow. You're standing at the beach, you've got your feet in the sand, you're at the water's edge, and as the tide goes out, so does the sand go right from underneath your feet, even though you think you should be able to control that. You can't. Grief does that to us. People are not going crazy. They're not managing well. In fact, as a minister and a clinician, at one point in time in my life, I did 19 funerals in 3 months. One of them was a car full of seniors who went off a mountain road during senior week. It happened to be a time in Vermont where a number of farmers were dying by suicide. What I learned in those services is the strong ones cried when they needed to, laughed when they needed to. The ones who were going to run into trouble were the ones that bought into the cultural, you know, pull yourself up by your bootstraps, hang tough, all the things that we say to people. Just a footnote here before I go on to the last part of this phase. In our culture, we are encouraged to think that grief is something, first of all, that you should be able to get over. I am here to tell you, you'll never get over the loss. You will get through it, but you will not get over it. It will not have this first phase impact on you. It will also always be something that has impact. The second thing is that in their inimitable wisdom, the people who developed the mental health diagnostic and statistic manual, which we call the DSM, determined to make grief pathological after 2 months. The reason they did this, I was told by one of the men who made the decision, is so that people could get insurance coverage through mental health work. The truth is, it's what's called a V code. They're not going to get insurance coverage for it. All it does is support the cultural myth that people should be, quote unquote, over it after 2 weeks to 2 months. Not true, not helpful. If you do everything you need to do, and I mean by that, laugh when you need to, cry when you need to, it still takes a year to a year and a half to go through this. Whether it takes a year to a year and a half, in addition to the personality type, developmental stage, age of the person, it also has to do with the proximity of a significant date. So if somebody dies a week before Christmas one year, it's going to take them through Christmas the next year. It's going to take them longer past the holiday to move through it than if it was mid-July. So just to keep those things in mind for yourselves and also for the people that you're working with. This is the point where people, I'm going to go ahead. Dawn, any questions?
There are no questions at this time, no.
Great. This is the point right here where I also get phone calls from people who are significantly distressed. This is the point in the grief cycle where people will, it's been long enough since the grief, the loss itself, and they're into the process of grieving. This is the point at which they will find themselves going through their day and all of a sudden thinking, I need to call them and tell them, and then catch themselves up short. This is the point at which, if this was an intimate relationship, you might turn to the chair where they would normally sit on a routine day, forgetting that they're not going to be in it. You'll catch yourself talking to them. This is the point at which people wake up in the middle of the night, reaching out to touch the individual, or having a conversation with, or they'll wake up crying again. And it seems a rather cruel trick of the mind for people to have this experience, but really what it is, and yeah, I'll finish the sentence. So really what it is it's the psyche taking this into a deeper place in the person. So it's actually literally incorporating the loss into the person's awareness on all levels. And, however, what happens is, and this becomes disturbing, it generally catapults the person back right into this very first part of this first stage of loss. And it's disturbing, it's upsetting. This is the point at which people say, what's wrong with me? Again, to be reassuring, there is nothing wrong with you. This is a part of what the psyche does to, quote unquote, make peace with the loss you've sustained. And going into this final segment, I won't call it a phase, it's a segment of the chart. What people experience inside in this last phase that is called detachment is, again, it's kind of an apathy, not caring, general indifference to whatever the meh phase, meh. A loss of interest in a number of things that they might otherwise have been interested in, particularly a loss of interest in socializing. I'll come back to that in a moment. Bill, when he began to develop this, called this segment of this a desire to withdraw and give up. And I took huge acceptance to that and have rewritten it and will again. And so this is the best I can do to describe to you what's going on in this phase, is to say, for those of us who remember the days where in preparation for trigonometry or pre-calculus, you went back and reviewed all the geometry and all the algebra you'd had until that moment, because you're going to put them together to go forward. This is what the human being is doing in this moment. They're going back and they're literally remembering, recalling all the things they were before they met this individual, all the things they learned to like about themselves or learned about themselves in relationship with this individual. They have an opportunity to put aside the things that that don't serve them well going forward or are no longer going to be part of their life going forward, and to move into re-entry with a renewed sense, a rediscovered sense, a recovered sense, and a reassembled sense of who and how they would like to be in the world. The things that were a part of their relationship with the other that they identified as themselves as part of lowered self-esteem, this is where that's beginning to be repaired, and new aspects of what it means to be ourselves in the world are created. If this is the place where I get calls from individuals thinking they're going crazy themselves, this is the place where their family members call. what they see on the outside is a decreased socialization. They notice the lack of new friendships being built. This bland expression is the closest to the kind of flat affect that comes with clinical depression. It's very different than the stoic, tough flat affect that comes at the individual moment of loss. And now this is something that's more sustained over a longer period of time. It's the absence of spontaneity and the lack of socialization that gets people worried about their loved ones. Again, this is because all the psychic energy is being used to redevelop a sense of self and what it's going to take to re-enter the world. Again, to remind you that our culture expects people to do this. In most cases, people get bereavement of 3 days. Probably one of the most healthy traditions for dealing with death has to do with a Jewish tradition of sitting Shiva, of rending garments. And the one that I find helpful and encourage people to do is to think in terms of a yahrzeit candle. A yahrzeit candle is a candle, ceremonial candle, although I find people can use a pillar. It's lit in a central place in the home on the anniversary of the death. Because our psyches log time differently than we do, they will register the time of death. And as people approach that time on an anniversary date, they will feel, whether they're conscious or not, an increase in the grieving, an increase in dealing with some of the somatic and psychological responses to that loss. I'm going to pause and see if there are questions about what I've said so far.
There are two. The first is, when does this stage of detachment become a concern?
Yeah, good question. Excellent, excellent question. Actually, these two phases, what begins as a response to sadness and moves into this bland expression, if somebody is stuck, quote unquote, in this for about 3 months, believe it or not, and they're not moving into any other phase back and forth, then I would be wanting to have a conversation with them around mental health intervention, psychotropic intervention, something of that sort. Go ahead, Dawn, with the second one.
The second is a little longer. It says, why the reaction or quote unquote taking exception to the notion of wanting to give up? Many people do, in fact, feel that way. It's certainly not the only option, and offering regrouping as an alternative is a great thing, but why deny that people may feel like they want to give up?
There's a difference between feeling that they want to give up and having that be a commitment to giving up. So the regrouping better describes the pulling back and the giving up as a phase in that, rather than a commitment to the giving up. Again, if you're dealing, so to put the two questions together, if somebody is dealing with this beyond 3 months and they're beginning to have suicidal ideation, that's a very different definition of giving up than the giving up that's part of regrouping. So I preferred it to have regrouping be the point rather than the giving up being a point. I just want to say, I realize we're running short on time. I want to respect your time. What I've done here today is something that I typically do over a multi-hour period, in some cases 6 hours. You've been real troopers. I appreciate your time and attention and commitment to the people that you serve and work with. And I want to encourage you to please send any questions that you have Janelle's way. Next week, what Dawn and I are going to do is go through a kind of what are similar things, what are different things. We can field some more of the questions that you may have next week. And then we'll begin to develop the ongoing resources for what may meet your needs that have been expressed out of these webinars. I think there's one more question, Dawn.
It's gratitude. Thank you for sharing your work.
Thank you. Okay. So please pass on your questions. Janelle, do you want to chime in and tell people where to find the, yeah, there you go. Good, thank you.
Absolutely. So Dawn and Claire, thank you again. And as Claire said, we do hope that everyone will tune in next week, same time, same place, for the 4th installment in this series. And in the meantime, if you had to miss one of these or would like to return to one of the webinars as a resource, please do just go to ACPE's homepage and then go to the bottom of that homepage where you can find a link to our YouTube channel. And then the part 1 and part 2 of this series will be the first videos that pop up there. And then because of popular demand, what we can do at the end of the series would be to come up with a synthesized version of all the different slideshows if you would rather